Thank you. Thank you once again, and over to you.
Thank you, Jyotsna and Vijay Kumar. Can I just check, is this audible? Am I audible? Is that okay?
Yeah.
Yes, sir.
Okay.
Yes.
So thank you for organizing this. And I'm going to try and share some thoughts and ideas that come from years of chasing a passion for community health. When we were in medical college, it was a subject to be passed, and not a pleasant subject to be passed. It's usually the worst taught subject in the entire medical curriculum across the country. But once I got working, I realized what a fascinating subject it is, and how much one can actually explore. So I'm going to aim this session for those working in hospitals and wanting to engage with communities around them. So that's the target way I'm going to go. I'm afraid this is going to be very heavy, but what to do? I'm going to push quite a bit of stuff, and I hope it'll be useful. I hope the PowerPoint contains most of the points I'm talking about, and that will be available to you later if you'd like to draw on it and use it in any way. So I also realize there are some gurus in the participants. There's Gift Norman, there's Elshiba Matthew, there's Shanti Mins, there's Priya Mac. I mean, they're all big shots in community health are also there. So forgive me if I break the rules of community health. I'm going to try and share my screen. I'm not technically very good, so if I get this wrong, Jyotsna, please correct me. Is this visible?
Yes, sir. Yes.
Yes, sir. Yes.
Yes.
Okay. Okay, so I realized that on the flyer, the topic given was community work in mission hospitals. Okay. I'm changing this to communitization. Okay. It might be a new word for you. We were using the word a lot with the National Health Mission when it first came out in 2005 in NRHM. And the idea of ASHAs and all was what we called communitization of the health system. So I'm suggesting that we think around communitization of or in mission hospitals. That's where I'm going to place this. I hope this is useful to you. And please stop me if you can't hear what I'm saying. I must put a statutory warning right in the beginning. This session is going to be rather heavy. It's aimed at people who are seriously interested in engaging with communities from their perspective. The light listener will be put off. Ideally, I should be doing this over a two-day workshop, but I'm going to squash it into an hour. But hopefully the content is on the PPT that you can use later. The last time I was asked to do this by CM.
Just a second. I'll get back to sir.
Sir, we can't hear you.
Johnny, I think your connection is.
I think your connection is lost, sir.
He's joining. He's joining back. He's joining back. Just a minute.
Oh, okay, ma'am.
Sorry, you lost me. I lost you.
Yeah, now we found you, Johnny.
I know, but I have to take a call on whether to switch my net connectivity. Any idea where you lost me right in the beginning?
Yeah, just in the first slide. Yeah, sorry.
Yeah, the first slide.
Okay, I haven't said anything important. Now I have to take a call whether to switch to my phone. I was on the Wi-Fi of the guest house I'm in. Let me try the phone.
Maybe, Dr. Johnny, you can put off your video and maybe the little less bandwidth will help. Usage will help.
I'm switching to the phone, yeah. Okay, is this clear? Am I clear now?
Yes.
Okay.
Yes, sir.
So I'm going to try again, huh? Is this sharing now?
Yes, sir.
Yeah. So I don't know where I lost you, but anyway, that was just a disclaimer saying I'm going to do something which is too heavy for this, but doesn't matter. I'll move on. So what I'd like to take us through is, this is the roadmap for this session. I'm going to begin with a personal statement on why I believe in community health. I'd like us to try and look at understanding the idea of community health from the viewing point of a mission hospital. I'd like to share some ideas from our work at Pisamkatak, and then some lessons learned from there, and then try and look at a roadmap for a mission hospital wanting to engage with communities. So this is the direction we're going in. I hope this is useful. Am I okay? Am I audible, hearing?
Yes, yes. Yes, sir.
Okay.
Yes, sir.
Yes,
Sure.
yes,
Thank you.
yes.
Okay, so why do I believe in community health, right? Now, my conversion to community health, if you like, started before I joined medicine. In 1978, when I was doing my +2 in Kerala, I won't go into the details, but an encounter with a beggar made me realize something which was very true. It is this, that all that we are and all that we have are a gift from God, given to us, but not for us. It's given to us to be used for others who did not get the opportunities we got. So when you're 17, everything is clear. This was the philosophy and the reason why I joined medicine. So when I joined medicine, medicine for me was a methodology to work for the people who did not get the opportunities I got. And then community health kind of hit me subsequently. The second point at which this kicked in very strongly was 1988, when I had finished my MBBS and I was working at Christian Hospital, Bisamgata, Odisha for 1 year as part of my bond or sponsored obligation service period, right? I walked straight into an epidemic of meningococcal meningitis. I was a bad medical student. I slept in most classes, so I didn't know that you could have epidemics of meningococcal meningitis, right? In my guesstimate, about 2,000 people died in a period of around 3 months, far more than COVID. Now, in our hospital, we converted the medical ward. It was just like COVID because it's a respiratory spread. And so what we now call PPE, we were wearing all those things. And we did a terrific job. But I kept watching the data. And at the end, I found that for about every 100 patients, one had come to hospital. So this was the reverse of the Good Shepherd story. You know, it's not 99 are found and one is lost. It is 99 are lost and one is found. And in the hospital, we were cuddling up to that one. And that was the shock of the denominator. And I was asking myself, okay, if after all these years, if we work for all these years, will we make any difference? There's another little baby who came in with neonatal tetanus. And I always ask patients where they're from. And the mother said her house was just about 1 kilometer from the gate of the hospital. And I ask myself, 40 years after Mission Hospital starts, if you can get neonatal tetanus from 1 kilometer outside your hospital, we have to ask some very basic questions. What difference do we make? So this is the second point at which it was really shaking me. And I was thinking, I think I will do community health. And now looking back in retrospect, looking back in retrospect, after all these years, I've finished work. We just retired. Mercy and I just retired 3 months ago. And realizing how much has happened, our calling was to be salt and light, to let go and to dissolve, to be the change we want to see or to be the change that God wants to see. And we were so grateful for the amount of love and satisfaction that we have received. Let me just show you a clip. I don't know if this will work, but if this works. This is a program where 34 of the program villages we worked with for 30 years organized a program to thank 7 staff who had retired in the last 10 years. And there were about 2,000 people present. And they had collected money, organized a vegetarian lunch, organized gifts for us just to say thank you. Where do you get this kind of love? You cannot ask for more acceptance and love than this. People came to say goodbye and thank you. So these are different reasons why I just love community health. I'm not saying the obstetricians and surgeons don't get love, but somehow this was different, right? So that's part one. Now I'm going to try and explain the concept of community health from the viewing point of a mission hospital. My take, okay? This is not exactly the gospel according to Park. It's my take, or my understanding of what happened. Now, if you look historically, yeah, to what I find as the origins of community health, especially for us in the Christian sector. If you go back around 60 years, exactly 60 years, 1964, the churches or church-run mission hospitals were facing a crisis. Across Asia and Africa, there were lots of mission hospitals, and most of them were manned or womaned by expatriate people coming from other countries, and the funding was all from abroad. And all these countries now were becoming independent in Asia and Africa, and they were throwing out the foreign missionaries. So there was a basic question. Along with this, after the Second World War, there was no money in the church in Europe. So they were asking the question, what do we do with these hospitals? So the same question that we discuss nowadays of sustainability of mission hospitals, they were discussing in 64. And so they held a meeting in a place called Tübingen in Germany. It's called the Tübingen Consultation. First meeting, second one was in 1967, where they asked the question, why are we in healthcare? And while their purpose was because they were wondering if we could shut down mission hospitals, the Spirit of God moved in that meeting, and they came out with a totally new understanding. They said, we are into healing, not into cure. And healing is much more than cure. Healing is restoration to the purpose of God. And then they said, this is probably best done in the community. So they searched for programs that have tried to practice healthcare in the community. They came across one in Maharashtra, the Jamkhed program, one in Indonesia, one somewhere in Africa. And they put those ideas together. They created an organization called the Christian Medical Commission, I think in 1967 or 70, somewhere around there, which then worked on these ideas. And there was excitement in the air. Now, if you go to Geneva, the World Council of Churches office and the WHO office are walking distance between, just from each other. So the ideas that were being discussed by the Christian Medical Commission got fed into WHO, and that's what led to the Alma Ata Conference 1978, where they said, health for all is our policy. That was the basis of India's National Health Policy in 1981. Then we lost our way, and then came the MDGs in 2000. And the National Health Mission in 2005. This is actually the milestones in a way of thinking, the benefits of which we are reaping now. So if I were to trace a theological or spiritual perspective on this, taking off from the Tübingen consultations, they said the healing ministry is God's. It is what God is doing in the world. All healing is from God. God is a healing God. Missio Dei. This is his mission, not ours. They said healing is much more than cure. It's restoration to the purpose of God. It is transformation. Then they said Christian ministry of healing belongs to the whole congregation, not just to the doctors and the nurses. And they said that would best be practiced in the community, amongst people themselves, through corporate or together action of the congregation. And that basically is what is called, we now call community health. They had an interesting definition for health, far better than the WHO definition. This is the Christian Medical Commission definition of health. Health is a dynamic state of well-being of the individual and the society, of physical, mental, spiritual, economic, political, and social well-being, of being in harmony with each other, with the material environment and with God. You'll notice all the Eastern schools of health thought talk about harmony, balance, Tridosha theory, yin, yang, the concept of being in balance. This is what they called health, and another word for that would be shadow. So what then is the aim when we as Christian hospitals go into community health? The aim is health for all, or a healthy community. And the approach we use is incarnational mission. Philippians 2:5-8, the Jesus methodology. He did not hold on, grasp his position in heaven. He empties himself, becomes one with. That dissolving like salt, that's the Christian methodology in community health. To be with and in, to be and to do, to share the pain of people, involvement, relationship. So this is very different from the academic kind of community health we pass exams in. This is not just a project or a program, but a vocation and a life. Now, if I ask that from a professional perspective, the same question, how do you see the term community health? What does it mean to you? A poorly taught, boring subject from 3rd MBBS? Or do you think it is poor medicine for poor people? No, I need a jeep, a syringe, a needle, and some staff to go to a village. Or do you see it as some romantic do-gooder pastime? When this doctor could have been sitting in the OPD and earning some money for the hospital, they're going off to some village. Or is this kurta-clad jolawalas who swear by it in conferences but never live it out? What does community health mean to you? What do those words mean to you? Now, the ultimate aim of all health work, whether it be neurosurgery or immunization, is health for all. The attainment of an acceptable level of health for all people. Physical, mental, social, spiritual, whatever you want, and not just the absence of disease or infirmity. So community health is one of the ways that this is put together. The aim of community health is a healthy community. So promotion of helmet use and treatment of head injuries, selling mosquito nets and treating cerebral malaria, research policy advocacy and healthcare delivery. It's never either or, it's always both and. So we need both hospital medicine and community health, not competing or antagonistic, but complementary and synergistic. So forgive me if this is sounding very conceptual. The first half is going to be a little theoretical, conceptual, and then we'll move to more practical areas. Now, you will hear a lot of words being used. We hear the word internal medicine. We hear the word family medicine. We hear the word social and preventive medicine or community medicine. We hear the word community health. We hear the word public health. This is a spectrum of spaces. Now, I'm sure there are professional definitions for all of these. They all overlap. But I'll tell you the secret I have found. Where does this spectrum hold? Yeah. One is that internal medicine focuses on an individual. I take that individual's history, examination, diagnosis, lab tests, follow-up. It is focused on an individual. As you come through this family medicine, community health, it becomes group. And when you reach public health, there are no individuals left. That's policy. You don't touch any individuals in public health. I mean, physically touch, right? So that's the spectrum. You go from individual to public. On the other hand, BBS allowed. We don't say it, but it is implied. The minute you use the word health, you're allowing everybody to participate. There's no turf issues there. So I like the word community health. That's where I would pitch my tent. But as a mission hospital doctor, what did I find different in working in the hospital and working in the community health side? I find 4, mindset differences that I had to switch on. My problem was I would be doing night duty in the hospital and doing community health in the field in my early years. And I had this constant difficulty of moving my head this way and that way. Some basic differences in the approach. First, the target or the beneficiary. In a hospital, the target is an individual who walks in through my gate and registers in the OPD or the IP section. That's what we call the focus of individual hospital medicine. Whereas in community health, the focus is a group. You might define the group as people of this panchayat or people of that district or people of that state or children or mothers or people with HIV. A group defined by a characteristic. So the focus is different. The starting point is different. It is the sick who go to a hospital. So the starting point in a hospital is the aiming to decrease disease. In community health, you're aiming to increase health. Both are in the same direction. One doesn't deny it, but the starting points are quite different. In a hospital, we always start the discussion with the question, what is wrong? You never ask a patient what is right. Because in the diagnostic mindset, we're looking for what is wrong. When you work in community health, you have to deal with a lot of normal people. And as medical people, we are not good at dealing with normal people. We need somebody to be sick for us to feel relevant. In community health, you don't have that luxury. You're sitting on somebody's veranda and that person is perfectly well, and you still have to find your relevance. The starting point is different. The third big difference is the power equation, right? In a hospital, the power is in the hand of the provider. The patient rotates from counter number 5 to 10 to 25 to 23. When you move into community health, the power is with the consumer. The power is with the community. You're on his turf. You're sitting on his veranda. You be very careful how you talk. It's like the difference between meeting a tiger in the zoo and meeting a tiger in the forest. Yeah. When you see a tiger in the zoo, you can do ka, 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 whatever you want. What can the tiger do? It can roar at you. But when you meet a tiger in the forest, you say namaste and you climb the tree. You don't fool around. Community psychiatry is like this. When we've had patients who are grossly psychotic and violent in the community, the only thing you can say is, Babu, mate maru na, please don't hit me. Huh? That's all you can really say. The power is on the other side. And the fourth difference is in the indicators of success. When we talk about a successful hospital, we use, for example, an indicator like the bed occupancy rate, right? But in community health, we have a problem. Does that mean if the whole town is admitted in the hospital, we're a successful community health program? No. So the indicators are different. In hospitals, we use utilization indicators. In communities, we use health status or outcome indicators. So these are just ways of looking differently, because I always had one foot on this side and one foot on that side. I constantly realized that there was a difference in the way we were looking. And then I just want to place this on the table, the whole idea of social determinants of health. As you sit in your OPD and you see patients, or you sit in the emergency and casualty and see patients coming in, start asking, why is this patient coming in? Why do people from that area have this disease while that area doesn't have it? And you realize there are reasons why some people fall sick and some people don't fall sick. There are reasons why some people deliver at home and some people deliver in hospitals. There are reasons why some children die and some people die only when they're 97, right? And these are social determinants of health. Various reasons, because it is not a level playing ground, right? There's a lot of variation here. And there are reasons why some people are sick and some people are well, why some get treatment and some don't. Yeah. And unless you understand that, we really won't make a difference. So I'm just throwing some concepts in. There is the mind school and the head school. Oh, sorry, heart school. That should have been heart school. My apologies. The mind school and the heart school. The mind school of community health is mostly academic epidemiology research. The heart school of community health is mostly romantic. Can you hear me? The heart school of community health is mostly romantic. We want to be with people. Obviously, we need both. You need heart and mind. You can't do either or. To me, epidemiology is the discernment of patterns, the ability to see patterns, the science of the denominator. To me, research is an attitude, not necessarily a project or an obsession. And we need to combine head, heart, and hands to get it right. Now, let's try and now take that idea of community health and put it into a mission hospital perspective. Right? And we're talking about communitization, a hospital which wants to be communitized, not necessarily run a community health project per se. Yeah. So that's what we're looking at, the idea of communitization. Now, my father, who used to be the chaplain of CMC Vellore, he argued, or he used to say, that institutions have life cycles. Yeah? And if you think of any of our mission hospitals, I don't want to name anybody because you'll get upset with me. There are these cycles. Stage one is a stage, the initial stage, vision without structure. He calls this the stage of struggle. This is the time when, like Ida Scudder starts off with nothing in her hand, or in Ottachatram, the haunted house, Ludhiana, wherever you look, you have that stage where a person or a group with a vision goes out. They don't have anything in their hands. That's the stage of struggle. And that is the most inspiring stage. You have then the stage of vision and structure are in balance. You got some funding. You're able to put this together. That's called the stage of efficiency and excellence. After some time, the structure overtakes the vision. We call that the stage of stagnation. And then you have stage 4, where the vision is dead, but the structure lives on. And that's the stage of detailed depth. If I were to elaborate that further, this is the way it would look. Stage 1, the stage of struggle. That's the most inspiring phase in the life of an institution. Even now, when we try to challenge young people, we'll talk to them about the stage of struggle. Those 3 knocks on the door, or whatever, right? That stage of struggle is the most inspirational stage, even much later. Then you have the stage of excellence, where there's a match between structure and purpose. My dad used to say, and then you get an award and you spend the rest of your life showing visitors around. Anyway, stage 3, it's slowing down. Vision is slowing down. And we're telling old stories. We don't have new stories anymore. And stage 4 is the stage of decay and death. The hospital may live on much longer. It might have a very healthy balance sheet, but the vision is dead. And self-perpetuation becomes the mission. Now, my father used to say this, and I asked him, is this inevitable in every institution? He said, no, not necessarily. If you are able to recognize when you go from stage 2 to stage 3, you recognize the symptoms of stagnation. The vision is no longer driving us. If you can recognize that and catch hold of the institution, go back to the drawing board, touch the pain of people, reinvent, redefine ourselves, you go back to stage 1. So you do stage 1, stage 2, stage 3, stage 1. And you can see examples of institutions that have managed to stay in the stage 1, stage 2, stage 3 process. Now, why are Christians in healthcare? Why would a mission hospital want to do community health? It's part of that 4-stage cycle process. What is community health? The aim is health for all. And in our team, we said anything that contributes to a healthy community is community health. And if you look at the way community health has been practiced by mission hospitals across the years, you'll see, I'm going to quote 4 styles. Not necessarily chronological in history, but just different approaches. Some people still do A, some people do D, doesn't matter. A were the roadside clinics. These were basically driven by compassion, aimed at increasing access to healthcare. They're very satisfying, very heartwarming. You go sit down under a tree and see 3 patients. There's no denominator. You don't know, you can come back and say, I saw 70 patients. Out of how many? Kitne mein se? That we don't know. And in one sense, it's like an extension counter of the hospital OPD situated under a mango tree for today. That's one methodology many of us are familiar with. Another methodology is to do outreach facilitation of hospital services. We are running a hospital service, but we add value by having pre- and post-hospitalization services. Yeah. So you might be a cardiologist, but you have follow-up in the community or oncology, whatever. Community screening, cataract. Very often it is outreach facilitation of hospital services. That's another way of communitization. The third is the project mode. It's usually funded by somebody, 3 years, 5 years, whatever. It's time-bound, funding-driven, huge questions of sustainability. And then we'll debate about rights-based approach versus provider approach. Sometimes we're just in subcontractor mode. Government wants to have something done. It gives it to you. You go and run 5 camps and come back. It's project mode. And D is the incarnational mode, which is a long-term person-centered, passion-based approach, journeying together. Same community, different project components. You'll find these variations in almost all our mission hospital community health programs. I'm just placing this there. And times are changing. We have to read the signs of the times. And remember that anything we say about one part of India, the opposite will be true in some other part of India. So we be careful when we generalize our statements. There's increasing urbanization, growing migration. Identity politics of caste and communalism is increasing awareness. The family unit is falling apart. There's a lot more longevity, aging. We've got increasing hatred and opposition. The high moral ground that we held on to is now rather shaky. There's increasing middle class, increasing expectations, increasing communication options, increasing purchasing capacity. But at the same time, there's also increasing marginalization and impoverishment of some. We have commercialization of healthcare. We are no longer seen as a service. We're seen as an industry. We have private hospitals mushrooming and booming. The focus is on curative care. Profit as a primary motive. Cost of care is rising exponentially. Healthcare is being quoted as one of the causes of poverty. These are some of the changes in the context that we're seeing. The community is also changing. Increasing demand, increasing utilization, increasing spending. And yet in some parts of the country, you don't have access to even the basics. Government provision is increasing. You have the NHM, the government has much more money now. There's an NGOization of government thinking, all sorts of new approaches, health insurance, cash transfers. You have the changing epidemiology of health and disease. Some diseases will decrease in course of time, leprosy, TB, malaria, polio, measles. Some diseases will increase over time, like diabetes, hypertension, ischemic heart disease, road traffic trauma. Epidemics of dengue, chikungunya, swine flu, Nipah if you want. And some health issues will always be with us. Obstetrics, neonatology, surgery, geriatrics, mental health. These will always be with us. So we are wading our way through this context. The other changes, technology, money, statutory regulations are becoming impossible. It is in this context that we are asking, I am a mission hospital and I want to do some community work. Where do we fit in the jigsaw puzzle? We need to sit back and see the larger picture. Do I want to be a catalyst for health? Do I want to be a facilitator of health? Do I want to be a provider of health? Or all three? Do I want to work on the micro, local level? Do I want to make macro changes? Should my focus be on the outcomes or on the process, the destination or on the journey? What should drive what I do? Resources or needs? My heart or my mind or the soul? And also we have to have questions asking, how can we be strategic in our involvement? There are two phrases I want to place here: situational excellence and social relevance. Situational excellence is asking, is this the best we can do in these circumstances? Social relevance is asking, will this make a difference to the poor? And I believe that in Christian medical mission, we have three key roles to play. One is to stand in the gaps, to serve those who nobody else wants to serve, to go where nobody else wants, to take on issues that nobody else wants to touch, to handle the gaps. Sometimes the gap is a community, sometimes it's an issue. Second, to set standards. कि ऐसा भी हो सकता है. Different ways of doing things and show that ऐसा भी कर सकता है. And thirdly, to train and mentor people with values. To me, whatever we choose to do, we should look at these three factors, these three lenses as well. So then, what would a mission hospital getting into community health be looking at? What we found is that the community health programs are a window of the hospital. For those inside to look outside, for those outside to look inside. They get a feel of what kind of people are inside the hospital. The hospital staff get a feel of what kind of places are our patients coming from. It can give us a rootedness in the people. It can help us to stay relevant and not go from stage 3 to stage 4. It can enhance the mission of transformation. So if you are a mission hospital thinking how, try and plug into your context. Find ways to listen, to discern. Look at your data. Home visit some of your patients. Discuss with people. Dream. Identify needs and strengths. Prioritize. Get involved. Build relationships. Start small. That's the kingdom way. And see money and resources as tools and not drivers. So I'm just going to place these ideas. I know, I'm sorry I ran through this. I hope later, if you get time to go through the PowerPoints, it'll give you things to think about. I'm going to now move from there to the story of what we have been doing over the last 30-something years. So Krishna Hospital, Bisamkotak, where I'm taking these ideas from, is a place in Raigada district in Odisha. I colored that star red for many reasons. We are about 400 kilometers from Bhubaneswar, 350 from Raipur, and 250 from Vizag. So beautiful part of the country, and that's where our hospital is located. This hospital was started in 1954. It's 200 beds, but sometimes you have 250 patients. The average bed occupancy is over 100%. Lots of surgeries, deliveries, and so on and so forth. And we also run a college of nursing, an ICSE school, an Adivasi school, and community work in 54 villages. So that's the context from which I'm trying to pull together ideas. As a hospital, we have not been able to write up a vision mission as yet. We just don't have the time. But we ask ourselves, what are we called to be? What does God want of us? What are we called to be? What are we called to do? We are called to be a faith-based community. We are called to share the pain of people, to respond and serve with love, and to be the change we want to see. And what do we do? How does that express itself? It's in healthcare, in training in health, and in education for children. So this is kind of a description of what we do as an institution. Now, let me into this place the community health story that we have. We call our work Mitra. Mitra means friend, but also our founder was Liz Madsen. So it's also got a full form, Madsen's Institute for Tribal and Rural Environments, but nobody knows that full form. Mitra is what we are known as. Now, our founder, Liz Madsen, was a Danish lady. She started the community health work in that region, going village by village, walking till she could not walk anymore when she was just too old, sitting with people, initially treating patients, then going on to education, starting the first books in the Kuvi language, which doesn't have a script, so she used Odia script so that people could get literate. It's really pioneering work and excellent kind of stuff. From that, we inherited what is today's community health department, the Mitra program that works with 14,000 people in 54 predominantly Adivasi villages. Now, the way I was trained, you're trained in project management, you start thinking in terms of SMART objectives, specific, measurable, achievable, realistic, time-bound. But you find that actually, if you try to be smart, specific, measurable, achievable, realistic, time-bound, you miss out the best things in life. Like I asked a professor in IIM Ahmad, do you love your wife? He said, yes. I said, is it specific, measurable, time-bound? Mark how gay, right? So there have to be a different way of doing things. And I realized this when I tried to practice community health the way I was trained, but people were dying. Our IMR was 200 per 1,000. Our under 5 mortality rate was 350 per 35% of children were dying before they were 5. And in one village, 6 children had died in 1 month, and my heart broke. We sat in that village and we cried. That is all we could do. We just cried because we had failed. This is about 2 years after I'd started working in that area. Every month I had gone to that village. They all died of post-measles bronchopneumonia. And so, sitting in that village and crying, we asked the village. We said, we failed. Whatever I have tried has not worked. And then somehow the words came out. What is your dream for your village? And that led to an entire change in the way we work. So we call those, this is the dream against which we work. We dream that one day all people will be healthy. A day will come when everybody is educated, when there's no more poverty, no more hunger. A day will come when everybody, regardless of caste, color, creed, gender, whatever, can live with dignity. So that's the Mitra dream. Actually, it's about 35, 40 points, but it falls into these 4 baskets. And that's what we measure ourselves against. You can make indicators for the dream. So this is the way we practice community health. We set the dream destination and then try to find. So the process that we've used, step 1, build relationships with the people you want to serve. Step 2, identify the unaddressed pain in that society. Step 3, share their pain. Step 4, dream of the end point. Step 5, walk towards that. We go along, but this is the methodology we've evolved over the years. A classic example is sickle cell anemia. If you want to serve people with sickle cell anemia, you get alongside. You try and understand their pain. And you realize the pain is not just the physical pain that they taught us about in college. The painful crises. There's a physical pain, yes. There's a mental pain. There's a social pain. There's a spiritual pain. All our genetic diseases in our country have got a caste connotation. So if there's a disease, doctors refuse to touch. And then you do health education and teach the children of the genetic basis of sickle cell anemia, and the child turns around and tells his mother, so if you were not my mother, I wouldn't have had this problem. And the father says, is this what I gave my child? I thought I was doing health education. I broke the family. And so you learn that you have to first relate with people. You have to understand, identify the unaddressed pain. Share their pain. I know it is not objective. I don't care. Cry with people. Share the pain. Feel the pain. We use the word compassion. The word compassion means to suffer with. Compassion means to suffer with. That's the Jesus methodology. Not sitting in heaven and blitzing the problem, but becoming part of. Taking the pain of the world on you. Share the pain. That's compassion. And from that position, dream of an endpoint and walk towards that dream. So this is what we call the Mitra process, the process through which one can actually find one's agenda. And so that led us to do a whole lot of things that we did not anticipate earlier. There's a whole range of things this gets into, against the dreams of health, education, economic security, and social empowerment, training, all sorts of things we'll end up getting to. I'll pick up a few of these as we go along. We have 2 health centers, one in Dakuda and one in Kachapaju, and we have nurse. The entire program is nurse run because doctors are endangered species in forest areas. You make doctor-centric programs, we just can't sustain them. It's nurse-centric, and nurses are far more systematic than doctors are. They don't take shortcuts. So our programs are entirely nurse run. It's a network of nurses and health workers. And then we put a notebook in every village, record all births and deaths, get a cause of death analysis, take your top 10 causes of death for the year, that becomes your priority, and you start working against those. So we have data from 1995 till now on cause of death, orbital autopsy. So some of the focus programs we have are on malaria, malnutrition, sickle cell, childhood hypothyroidism, hypertension, diabetes, according to what that program is. And the community-based health management information system, simpler, no computer, a handwritten system, tells us whether we were moving forwards or backwards. And so the aim is a healthy community. The process is people-centered and nurse-managed. Variations. Over time, we're doing very different things. The things we did 20 years ago, we're not doing now. Those have dropped out. As the issues change, we change the strategy. And now all dreaming sessions don't go in the direction you wanted to go. So one village dreamt that they'd have a school of their own. And that was not on our agenda, but it was their agenda. And it's their life anyway. So 16 villages formed an association, the Malkand Anchalika Sangha, and in 1998 started a school. And it's our job to run it. It's an Adivasi school, Kui medium, 1st to 5th standard. And education is in their way. So for example, you'll see goats in this picture. The community decided that when I was retiring and leaving, they said, once the old man goes, people will stop donating money to us. We'd better find another way to finance the school. So now every child coming to school brings a little she-goat to school. Mary had a little lamb, that kind of an idea. You put the name of the child on the goat. The child must learn how to look after goats. That's part of education. The goat will stay at the school for 5 years. At the end of 5 years, the child can take the goat home during graduation ceremony. But all the kids born to that goat will belong to the school, and we hope to sell those goats to run the school. We can work on finance methodologies. There are all sorts of ways if your heart is in the right place. And this was last year when we celebrated 25 years. Now, we go on to different forms of education inputs, preschool, government schools putting in voluntary teachers, preschool program, we call it MKB, youth programs, youth fellowship, relationship with people, identifying pain, sharing the pain, and dreaming. You come up with different ideas as we go along. We engage with a lot of youth. We do offer internships, fellowships, all sorts of things. We have a club for the elderly called Aging with Dignity. I'll pick up a few of these and discuss how you actually think through an idea. We also have a training and resource unit that shares ideas with people. I'll jump this for now. Now, from all of this, let's pick up some of the lessons learned. I hope you guys are still here. I haven't sent you off. The idea of dreaming as a method of setting the agenda. Community dreaming sessions that I talked about. We believe in dreams. For every program we do, we ask the question, what is the dream? What should come out of this? Not how will we do it? Don't dream vehicle, dream destination. At the end of it, what should come out? What's the purpose of what we do? Right? So if I look at this one, look at the last column. This is our education dream. Look at the last column, the red wala, right? We said that education is knowledge, skills, and values. But when our children finished 10th standard, that was not enough. We found suicide. We found young people unable to cope. And so we said what they need now is critical thinking, resilience, and hope. And we started working on that. And then we found that even to be a good dacoit, you need critical thinking. Yeah, you need to know which house to steal from. You need resilience. Even if the police catch you, you rob again. You need hope. Today, pickpocket, tomorrow, ATM. So that needs a direction. And so we said, so what is the aim? The aim is bhola manushya hai bata, to become a good human being. Then we had to ask, who is a good human being? And we said that is reflected in healthy or positive behavior, attitudes, and relationships. And then one of the tribal members of our staff said, that is not enough. We need to go further. We need to create servant leaders and visionaries or dreamers for society. So this is the way we work. You get an idea, you work in the field, you dream, and then you start constantly revisiting that and enhancing the dream over time. So this is what we call dreaming methodologies. Like I said, here's that process. Step 1, build relationships with the community or the group you want to serve. You are working in an area, you find there are very poor people in some subsect. Go and make friends. Only then you will know. Buying a birthday gift for a friend is very different from buying a birthday gift for somebody you don't know. Step 2, identify the unaddressed pain in that community or group. Step 3, share the pain. Step 4, dream of the destination. Step 5, start walking towards the dream. Step 23 is get the money. Whenever the money comes early, you run into a different kind of planning process. Then the aim is the budget. Always the best programs you get are when your money is less and your heart is greater. Let the money come later. Don't wait for funding to start working. Dream and work, and the money will follow. We don't work for a poor God. We work for the God of all the earth. Here's another tool that we find very useful. Okay, so you went to the community and you found various health problems. Your question is, which one should I take on? Should I, you did your survey and you find a whole lot of people have got a common cold. You've got some people with cancer. You have lots of people with TB. You have some people with skin diseases. Which one should I work on? This is a formula which we teach every single nursing student who studies in our college to do. All our GMs and BSc nurses, everyone knows how to do this. We do a scoring. You take the list of problems and then you give a score of 1 to 9 for magnitude. That is how many people are affected by the problem. For importance or severity of effect, which is asking the question, or for the person who is affected, how badly are they damaged? Does it kill them? Can it kill them? Does it make them disabled? You give a score for that. The third question we ask is it something for which you can do something? Is it vulnerable to control? Is there a controllability? Some diseases you can't do anything about. Some diseases, even with little input, you can control. And C is the cost of controlling the problem in a unit. So we do a scoring on this, and it helps us to ask the question, what should I take on first? Priority is proportional to magnitude, importance, or severity of effect, or vulnerability to control, and inversely proportional to cost of controlling unit. I learned this during CHP in Vellore. But I find this is really useful even today to help us to discern where we should put our energy, how do we be strategic. I'm just throwing a whole lot of ideas in the air on how you can respond in different ways in community health. Now, this is a storyline that I created when I was teaching BSc nursing students in Vellore, right? This is a story of polio. And I must tell you that for those who are not medical on this, polio is a disease that is caused by a virus, the polio virus, and it comes through contaminated water. If a person has poliovirus in their stomach, it comes out when they pass stool, and that stool contaminates drinking water, like if you drink from a river, and then you may get your polio. Just putting that there for those who don't know the background to polio. So this is a story of a boy called Raju in a village, right? A little boy called Raju running around the countryside, enjoying themselves, far away, no road. The borewell has broken down a long time ago. Nobody comes to repair it. And of course, they've never heard of a toilet. All is well. Raju is in his village. One day, the A&M comes to the village saying, immunization. Raju and all the children run away. The A&M gets so angry. She says, I came here with such difficulty. Nobody came for immunization. I'll never come again to this village. One day, Raju falls sick. He has some fever. Her mother takes Raju to the local practitioner. He gives him an injection. Sometime later, we find that that leg on which that injection was given starts becoming weak. It's painful initially. Now there's no pain. It's slowly wasting. Raju now cannot walk anymore. His parents look after him with great love. They can't educate him. They can't teach him anything. And after they die, there's nobody to feed him. Raju becomes a beggar. Okay, so we use this in our workshops. And the question we're asking is why? Why did Raju become a beggar? And so normally when I do this on a blackboard, you have everybody contributing reasons why Raju became a beggar, and you ask a why to everything. So Raju became a beggar because he got polio. Why did he get polio? Because he drank contaminated water. Why did he drink contaminated water? Because the borehole is broken and there are no toilets. Why does that happen? Or Raju became a beggar because he didn't get immunization. Why didn't he get immunization? Because the nurse refused to come back again. Why didn't she come back again? You come to attitudes. Or because of wrong treatment, whatever. So we do this analysis, we call it the why game. You ask this chains of whys across and you get that picture on the board. Now the question is, if I had to do something so that Raju did not become a beggar, I could have cut the story at so many points in the story. Raju became a beggar because of a whole series of social errors we made, right? You could have cut the story at different points and Raju would not have become a beggar. Yeah. So when you put that onto the same transparency that I used to use, this is what it looks like. Maybe if health education had been done, maybe if toilets were built, maybe if there was clean drinking water, then Raju wouldn't even have got the polio virus. Or maybe if he got immunization, even if he got the polio virus, he wouldn't have got the disease. Or maybe if they had got the diagnosis correct, they had admitted him in hospital, treated him correctly, he would have got the disease, but it wouldn't have gone on to paralysis. Okay, maybe he got the paralysis. If he had got physiotherapy, occupational therapy, some job training, he wouldn't have become a beggar. So you can argue that any of these things could have stopped the story. In community health, we have words for this. That first bit is called health promotion. Immunization is what we call specific protection. Early diagnosis and treatment, disability limitation, and rehabilitation. We call this primary prevention, secondary prevention, and tertiary prevention, or primary level of intervention, secondary interventions, and tertiary interventions. Now, if you just grasp this idea, you can apply it to even hypertension if you want. Understanding the disease and creating a program. So let me give you an example of hypertension, where we took the same concept and broke it down for our community. Today, hypertension is the single most common disease in adult males in the tribal community, in our community. So how do you do it? You put down your risk factors, and then you're asking primary prevention, specific protection, early diagnosis and treatment, and if they got the complications, strokes, heart disease, kidney disease, how do you manage that? And then this gives us a framework with which to work. I'm just trying to throw an idea that you can take the old ideas of community health, of primary health care, and apply it even to the issues that we face today. Just ways of working. Yeah. So in each of our work, we found a challenge and then a response to that challenge. So we looked at children in primary schools, and we dreamt that one day all school children will be healthy, health aware, agents for health change. And the response is a school health program. So we wrote a little book with the knowledge that we thought children need to know. We introduced annual health checkups, subsidized mosquito nets because malaria was our biggest problem, create subsidized treatment at the hospital, and you have a school health program. Or let us say we looked at the elderly, and we found the elderly in our communities, they're respected in word. Everybody says nice things, but neglected in deed. Very often feeling lonely, especially if one spouse dies. Very often feeling humiliatingly dependent and without access to basic care. So we asked the question, can we dream that our elderly people will be allowed to age with dignity, yeah, with access to basic healthcare needs? And the idea through discussion became a program that we call Aging with Dignity, where over 650 people pay 10 rupees a year as their subscription so that they have a right to demand. They get a card, and the nurses will visit every month. And we have an annual get-together on Gandhi Jayanti when we can get together and curse the young people. And also we can give gifts to the elderly, but we get the young people to give it to the elderly, touch their feet, take their blessing, give the gift, maybe a dhoti or a sari or something. We buy the gift, but the young people must give it. And we tell people, your children are watching you. How you treat your elderly is how you're going to get treated one day. So this is called aging. So these are different kinds of ideas we've developed over the years, which have worked really well for us. You could ask the question of health costs. Women's groups were putting a little money together to save money as SHGs, but they said one admission in your hospital and all our savings will go. So can they have their own health fund? And this led to something that we call MCHIP, the Mitra Community Health Insurance Program, SHG-based solidarity fund. They put money aside and they subsidize care for their own members. or village health funds, or a referral subsidy fund. So you sense a problem, right? Identify unaddressed pain, share that pain, dream of a solution, and then walk. And the idea evolves into programs and strategies. Like I said, sickle cell anemia, genetic problem, affecting vulnerable communities, lifelong burden of pain and crisis. Children are the most affected. Burden is on the primary caregivers. So can we dream of that everybody with sickle cell anemia will be able to live with dignity and health? That became a sickle cell anemia club. We use basically the Positive People's Network idea. Meet as a support group every 3 months. There's home care education. Happened to you the last 3 months. So different ways. They don't change the world, but they communitize your hospital because now you're dealing with people. But the question is, does it work? All this is fine, makes us feel good, takes fantastic pictures for the annual report, but are we fooling ourselves with romantic mumbo jumbo? And that's why you need data. And so we track our data across time. And so an IMR, which was 201 per thousand, came down till 29 and then went up again. But not that high, went back to somewhere around 59. Or the under 5 mortality rate came down from something like 300 to something like 64. We track these because without that, you will not know if you're fooling yourself, if you're going forwards or backwards. So simple data is useful. Now, the thing with health is not nirvana. It can go up and down. Whereas we believe now in investing in education. If you can't do community health, do community education. And you will find those indicators never go down. They only go upwards. So the female literacy rate in the 16 villages which decided to start their own school was 1.2% at the time of the starting of the school. It's reached 48.6%. We had only 2 metric pass in history. Now there are 431. So that is so satisfying. And that's the only sustainable field in community work is education. You know, many years ago, some engineers from MIT, the US, walked into our school. They were sent there by the Tatars. And I was telling them how we run the school, just love and fresh air, people donate something. And they said, doctor, you cannot do this. This is not sustainable. So I said, you know, I've got a terrific sustainability plan. So they said, what is it? I said, I have to teach you an Indian word. They thought I'll say jugaad. I said, no, Uparwala. God is our sustainability plan. He is what has made it through. But the fact is this, the day we started the school in 1998, it was unsustainable. It could have shut down in 1 day. Today in 2024, it is unsustainable. It can shut down tomorrow. But in the meantime, some 700 children became educated. They will never become uneducated again. That is sustainability. Don't worry about sustainability of finances. Don't worry about sustainability of operations. Ask sustainability of impact. What will stay when the project ends? That's the question we should be looking at. And that's what we're playing with. And so we just looked at data between those who got to study in the school and those who didn't get to study in the school, because selection is by lottery from the same villages. And you can see the data shows that education achievements are much better for those who won the lottery, got to study in the school, than those who didn't. So this is a randomized controlled trial by accident. But look at the last line. We found that those who studied in the school had a 1.5% death rate, you know, across the next 20 years, as against 3.8% in those who didn't win the lottery or didn't get a chance to study. In other words, education is long-term medicine. Education does more for health status than health programs itself. And it's something for us to think about. If we really believe in transformation, invest in education. So let me take you through the last section, a roadmap for Mission Hospital wanting to engage with communities. How do we move forward? First, I'd suggest accept that we are an instrument. We are a method. We're not the goal. If self-perpetuation is our mission, what's the point? 2, imbibe the philosophy. A, the aim is health for all, a healthy community. Our aim is not health care for all. It is health for all, a day when everybody is healthy. B, the calling is to share the pain of people. C, the method is the Jesus way. Involvement, engagement, becoming part of, taking pain on ourselves. Think communitization rather than just project. Look at your data with a community lens. Take your data from your OPD and your IP. Disaggregate the data. Think denominator. Who is coming to your hospital? Who is not coming? How many are dying outside? What communities are getting left out in this process? Look at your data with a community lens. Use the Mitra process, the 5 steps. Build relationships with that community that is getting left out or being marginalized. Identify their unaddressed pain, share their pain, dream of the destination, walk towards the dream. So these are some of the things we found. Then start engaging with the community in all possible, feasible ways, given your setting. Everybody cannot do the same thing, doesn't matter. For example, maybe you can do home visits. You had patients who were admitted and went back. Just go and visit them at home. It makes all the difference. You could do NCD screening, risk factor screening programs. At the end of the church, when everybody comes out, get their height, weight, BMI, BP, if you want an RBS check, do it in the clubs. These are ways of communitizing our hospitals. You could try childcare. Maybe you will start a creche inside your hospital. Maybe you do tuition centers. Your wards are empty. Why don't you run spoken English classes? Somehow, most of our doctors are better at English than others. Why not? Why is that not communitization as well? Maybe you'd like to look after the elderly. Maybe, and there are some key health issues where a community-based approach has huge advantages over an institution-based approach. These include non-communicable diseases, because there's so much that needs to be done with NCDs, which cannot be done in a hospital. It's huge lifestyle issues. Palliative care is far better done in the community than in a hospital. Geriatrics, mental health, disability and rehabilitation. These are areas that are far better done in communities than in institutions. A combination approach is the best. And my final slide, apologies for trying to overload. I'm so sorry I've pushed so much onto you in one shot. It takes 12 years for organizers to forget the last one. We might be back, but I hope this PPT will be useful to you. Thank you. God bless.